Thank you for joining the AAN's Resident Lecture Series Subspecialty webinar. Today's topic is Women's Neurology, a subspecialty for half the population. Our presenters today are Dr. Esther Bui and Dr. Sara LaHue. Dr. Esther Bui is an associate professor and clinician educator within the Division of Neurology, Department of Medicine at the University of Toronto, Canada. In 2015, Dr. Bui created an advanced training program for the resident physicians to learn more about women's issues in neurology. In 2017, this program became the first accredited Women's Neurology Fellowship Training Program in Canada. She is the founding director of this fellowship and the director of the Epilepsy Fellowship Program. In 2024, with colleagues in Harvard, University of Pittsburgh, UCSF, and AAN leaders in the field, the Women's Neurology curriculum was published and endorsed by the AAN, laying the groundwork for new collaborations in North America and around the world to advance women's neurology education. She has published 50-plus scientific papers and books, including a clinical handbook, Women with Epilepsy, a Practical Management Handbook. Dr. Sara LaHue is an assistant professor of neurology at UCSF in the Neurohospitalist Division. She is Director of Education for the NINDS-funded Sex and Gender Enriched SAGE Neurology R25 and an affiliate member of the UCSF Bixby Center for Global Reproductive Health, the UCSF Women's Health Clinical Research Center, and was recently inducted into the UCSF Academy of Medical Educators. Dr. LaHue completed medical school, residency, and neurohospitalist fellowship at UCSF. Thank you both for presenting today, and Dr. Bui, I'll turn it over to you.
I'm delighted to be able to share this platform with Dr. LaHue, who is a leader in this field as well. The objectives for the next hour will be to highlight the importance of women's neurology and why this is needed. It's an important emerging subspecialty that really reflects not just precision medicine for the future, but also precision medicine for our historical data set that really often have neglected sex and gender issues in the data and research. And hopefully we'll be able to highlight the approach to neurological care in a particular and important lifespan window for women, which is pregnancy, through two important cases that highlight and contrast the important considerations for care in this population. Here are our disclosures, and there are none that impact the content of this talk. Why do we need women's neurology? Many times, and in fact, a study led by Adi Peretz identified that there are important missed opportunities and gaps in our existing residency program and training programs, in that many trainees may not understand the importance or implications yet of why women's neurology and an education curriculum on sex and gender informed neurology is important. And it's important because sex and gender issues are prevalent throughout all aspects of care we provide for our neurological population. For women in particular, there are different important lifespan windows that are important, both on disease implications, but also therapeutic decisions. From childhood and adolescence with catamenial or menstrual-related exacerbation of illnesses like epilepsy and migraine, to genetic predispositions for certain diseases and responses to medications. Equally important, pregnancy, postpartum and post-pregnancy care, and menopause, perimenopause, and aging. There's a saying in this field where menopause is having a moment, but I would like to actually change the word moment to momentum, because it's only the beginning of what we need to know and do more for our patient population. And it's equally important not to just focus on the biological factors, but the significant gender implications of being a woman in our society, the caregiving responsibilities, and much of the invisible work that many of our women patients do in being oftentimes a primary care provider for important family members that need ongoing care throughout their lifespan. What's interesting is that the science really does not reflect our population. If we look here at the pie charts in the neuroscience data that have been reported to date as of 2020, we know in the gray area, research studies that did not report or consider sex as a biological factor. And the gray area for human neuroscience data is much larger than for rodent science data. So in fact, the neuroscience body of work and research, we know more about the rodent brain than the human female brain. And it's changing, and hopefully this will be the beginning of a new chapter of sex and gender informed neurology. We did a recent scoping review of published neuroscience and neurological data around the world, and we should be very proud in North America, as well as in other important emerging parts of the world, that we are really one of the leaders in sex and gender informed research in both Canada and the United States. What's interesting when you look at this body of literature in existence is that to the right, you see the 4 pie charts where there are different subspecialties of headache, demyelination, epilepsy, and stroke. And in the yellow or orange pie chart, that is the area of research that's focused on pregnancy. So if you can see here that not only are we leading the way, but pregnancy is an important fundamental emphasis of research. What is under-researched and under-studied is aging, perimenopause, and menopause. And so there is a huge opportunity for us to build on the momentum that is building among other areas of research in our obstetrical, gynecological, and women's health space. With that, I will pass this over to Dr. Sara LaHue.
So one reason why we're really excited to be speaking with you all with the American Academy of Neurology is that recently Dr. Bui and I and several of our colleagues published this curriculum that you can find on the AAN website that is a series of core competencies really for neurology trainees, but I think it's something that really all of us as neurologists can benefit from when thinking about topics that pertain to sex and gender across the lifespan. And so you can see that we break it up into a couple different sections. At the top being women of reproductive potential, then you have pregnancy, postpartum, and lactation, and then at the bottom, aging and menopause. And so today we'll be focusing more on the middle green section on pregnancy, postpartum, and lactation, but just want to make sure that you are aware of these other sections that you can find on the website if you're interested. So in terms of the organizational structure, of this outline of core competencies, we then broke it down by different subspecialties. So you can see here that we have subspecialties of headache and pain, cerebral vascular disease, demyelinating disease, epilepsy, neuromuscular, and emerging fields. And an example of emerging fields would be my subspecialty, neurohospitalist, but there are certainly many others as well. And so today we'll be really focusing on just a couple of these, being cerebral vascular disease by way of my subspecialty as a neurohospitalist, and then Dr. Bui will return and speak with us more about epilepsy. So one of the reasons why it's so important to talk about this topic is that as neurologists, we're often faced with this dilemma of how do we best counsel patients who are interested in becoming pregnant or who already are pregnant. And one reason why this is so important for us is because of all of the medications that we prescribe for various neurologic conditions, and the fact that it's very common for people who are pregnant to take medicines as well. And so at least within the United States, some recent data suggests that at least 70% of women who are pregnant take at least one prescription while they're pregnant. And then one of the challenges, though, is that while medications are commonly used, we actually know very little about the safety of these medications during pregnancy or during lactation. And with less than 10% of these medications actually being FDA approved with adequate safety data, either during pregnancy or with lactation. And so this creates a really key dilemma for us as neurologists, and also just within medicine more generally when thinking about how do we provide standard of care and evidence-based medicine for people during these important periods in their lives, but also doing it in a safe way, but also providing, again, the same standard of care that any other patient might get. And so this ends up being one of the key dilemmas when thinking about management when people are pregnant. And this is becoming more important as we think about access to healthcare in the United States. And so these are recent data just looking at the development of maternity care deserts in the United States. And so what that is an area where there is no access to a provider who is trained in obstetrics. And you can see that in the United States, this is a kind of lack of healthcare that is that's actually growing in our country, with at least 35% of U.S. counties being classified as maternity care deserts. And so this means that as neurologists and as other, not just as neurology, but widely in medicine, I think we have a responsibility to also learn how to properly care for people who are pregnant within our specialty so that we can provide counseling in this area as well, given the lack of access in these areas. And also, I think it highlights the importance of telemedicine and teleneurology specifically as a way of helping to ameliorate some of these discrepancies in care. And pregnancy ends up being a pretty high risk period for people in the United States. Certainly the numbers in absolute terms are small, but I think it's important to point out that 2/3 of US pregnancy-related deaths do occur during the postpartum period. And so you can see here the distribution of pregnancy-related deaths by timing of death in relation to pregnancy from 2017 to 2019. And 65% of the reported deaths occur in the postpartum period. And this is continuing up to the full year postpartum. And so when talking about pregnancy, much of what we're talking about is while the person is pregnant, but also thinking about important risk factors for neurologic conditions and complications during the time of delivery, and then also things that might emerge during the postpartum period too. And so when I'm approaching peripartum consults in the hospital, there are a couple categories that I think about. So first of all, thinking about whether or not the condition I might be seeing, the patient I'm seeing who's presenting with this condition is dealing with an exacerbation of a pre-existing neurologic condition. And we'll get into a case of that shortly. The second category that I see more often is a neurologic complication of pregnancy itself. And then the third category is it just an unfortunate coincidence of timing? So just a coincidental development of neurologic emergency or of a condition that's not necessarily due to the pregnancy, but it's happening at the same time. So we'll really be focusing on the first two. And just to give an example of how one might approach generally this idea of an exacerbation of a pre-existing neurologic condition, I think conditions like headache and epilepsy end up being good examples of this. But really the first step is just ensuring that you feel confident that the symptoms that the patient is presenting with really are consistent with their known pre-existing neurologic condition. Is the headache exactly the same? Is the seizure semiology exactly the same? Are there any potential red flags that might suggest that you're dealing with some other etiology here? But if it really does seem like what you're dealing with is consistent with this known condition that the patient has, then we're talking about an exacerbation of that. And how might one think about management and trajectory? And so those things might be based on a couple of these categories. So first of all, thinking about where the person is during their pregnancy or postpartum period, and understanding how sensitivity to hormonal changes during those times may increase the risk of an exacerbation of this underlying condition. And Dr. Bui will get into that more with an epilepsy case later on. We can also think about expected physiologic changes during pregnancy and the postpartum period. And so, for example, the importance of checking medication levels or changing doses, which we'll talk about more in detail. And then also, I think it's important to remember environmental factors, discussing sleep, hydration, nutrition, and also inquiring about safety in the home, and just ensuring that we're addressing any of these environmental factors that could be risk factors for exacerbation of an underlying neurologic condition. So the category that, at least in the hospital, I end up seeing more often is going to be the second category, which is neurologic complication of pregnancy itself. And so for that, we have a few cases to talk about, a tale of two Sadies, as it were. And so I'll be focusing on the first Sadie on the left side of the screen, who is a 36-year-old woman who has a history of migraine. She is G1P0 via IVF. And when she's seen by a neurologist, she's had already delivered a healthy baby boy by C-section. And it's postpartum that then, around 8 days postpartum, she ends up developing blurred vision and headache and presents to care for those reasons. Her vital signs at that time, she's hypertensive to the 170s, over 110s, whereas her baseline blood pressure is in the 90s over 60s. She is drowsy, but able to answer some simple questions. Her labs show that her CBC and liver enzymes and renal function all look normal. However, she has a urinalysis that shows an elevated protein to creatinine ratio, which is potentially concerning here now for the development of preeclampsia type criteria. And then when she's en route to the CT scan, she becomes unresponsive and she has a witness convulsion. And her neurologic exam at that point identifies a left hemiparesis, though she is able to still localize on the right. And so what might her diagnosis be given this constellation of symptoms and signs? Well, she ends up getting triaged instead to an MRI, which you can see here shows an area of signal abnormality involving the transverse sinus, suggestive of a thrombosis involving the right transverse sinus there. Which then is substantiated on MR venography time of flight imaging. And so this ends up highlighting how one may also meet criteria for preeclampsia, but there may also be other underlying reasons for an acute decompensation like a cerebral venous sinus thrombosis. So maternal stroke in and of itself is fairly rare, again, by absolute numbers, but it's important to understand when the incidence of this is going to be higher in the peripartum period. And so the high risk periods end up being around the time of delivery and then especially postpartum. And maternal stroke pathophysiology, why is it that we might end up seeing higher rates of this in people who are pregnant or recently pregnant? There are lots of reasons for this. And again, it's an area of active investigation. But some major categories of this include the physiologic changes in pregnancy that occur that are just normal parts of pregnancy. So thinking about on the top left side of the screen, hemodynamic and vascular changes like increase in cardiac output, systemic vasodilation and venous stasis. There's also changes to the coagulation system and the development of hypercoagulable state, which you can imagine at the time of delivery is something that may actually be highly desired, but unfortunately could lead to vascular complications like stroke. You can also think about potentially pathological conditions in pregnancy on the top right, thinking about the development of hypertensive disorders, peripartum cardiomyopathy as a potential complication. And so all of these things together, both the typical physiologic changes in pregnancy, as well as some of these pathological conditions that may occur, really end up creating this perfect storm that leads to an increased risk of cerebrovascular events during this important time. Cerebral venous thrombosis is something that's going to be especially high risk, again, thinking about the increase in clotting risk. And this is something where, again, the rates are going to be much higher in the postpartum period, especially within the first few weeks postpartum. And one reason why it's important to screen for some of these complications of pregnancy, when I talk with trainees about questions we might ask really all patients in terms of their history of pregnancy, but also just asking about other complications that may have occurred while they're pregnant. So any history of miscarriage, blood pressure, high blood pressure, eclampsia, preeclampsia. Screening for these adverse pregnancy outcomes is something that's now actually recommended by the American Heart Association, American Stroke Association, in their 2024 guidelines for primary prevention of stroke, where you can see in this algorithm that the presence of these complications of pregnancy may actually portend increased risk of cardiovascular and cerebrovascular risk later on. And so it's encouraged to screen for these risk factors, and if present, then to think about addressing any potential modifiable risk factors that that person has for cerebrovascular disease. And so this is where, again, in the same paper, they end up talking about Life's Essential 8 in terms of the potential different categories that one might be able to address for modifiable risk factors. And so again, this is one reason why it's important for us to just systematically screen for adverse pregnancy outcomes in our patients. And so I will hand it back then to, after this, I'll hand it back to Dr. Bui. So epilogue for this patient, she was acutely treated with IV magnesium and labetalol because of the concerns around preeclampsia, then leading to eclampsia, seizure, and also treated with levetiracetam in the setting of a seizure. But then with the thrombosis that was found, then also starting low molecular weight heparin. After clinical stabilization, she was switched over to oral anticoagulation. In this instance, warfarin was the preferred choice because of an interest in breastfeeding. At a follow-up appointment at 1 month, thankfully back to baseline without any residual deficits. And later there was a hypercoagulable workup that was pursued that was ultimately negative. And so again, this shows how this sort of presentation of seizure with with multiple risk factors and signs for preeclampsia leading to eclampsia, maybe one potential cause, but then also thinking about other potential underlying etiologies for seizure, like in this case, venous thrombosis. So now I'll hand it over to Dr. Bui.
Great, thank you, Dr. LaHue. The previous case really was a wonderful representation of the pregnant patient with a neurological condition. And this second Sadie is a neurological patient with the pregnant condition. And I think that's a really important contrast to recognize, is that these are two very different contrasting stories. So Sadie St. Jerome is a representation of a patient of mine who became pregnant. I was under my care for a number of years and wanted a pregnancy, but couldn't achieve one until IVF was successful. And she was on Lamotrigine, and throughout the course of her first and second trimester had breakthrough seizures, but fortunately delivered via C-section a healthy baby boy. But 8 months postpartum, much like our first Sadie, developed double vision and headache. On exam, her blood pressure was 120/64, and her baseline blood pressure throughout pregnancy was reported as 95/50, and so slightly elevated. She had end gaze nystagmus, eyelid myoclonus, and appendicular ataxia. An urgent EEG showed 4 to 6 hertz polyspike and wave activity. What is her diagnosis? For those who like puns and hidden Easter eggs, Sadie-Gievant syndrome is really a representation of epilepsy with eyelid myoclonus. And neurology of pregnancy and epilepsy is unique in that, unlike many of the other neurological conditions, many women don't have a choice to suddenly stop their medication. And in contrast, these medications are recognized to have an associated increased risk of major congenital malformations or teratogenicity. One really important understanding of pregnancy care for women with epilepsy is that the pregnant body, in contrast to the hypercoagulable state of the stroke risk factors, it is a supersized superhero version of what the pre-pregnancy kidney and liver does. There's increased renal blood flow with dramatic reductions of renally clearance medications like levetiracetam, gabapentin, and pregabalin. As well, there are alterations in blood volume and blood protein concentration such that there is much more dilutional and protein-bound relational factors to further drop our important serum drug levels. In addition, the liver is induced. Interestingly, there's a interaction with estrogen and the liver's glucuronidation process, which is instrumental to lamotrigine metabolism. And so with induced hepatic oxidation as well as induced hepatic glucuronidation, there is significant drops in some of our most important seizure medications. On top of that, the biology of this is a lot of the cultural implications of women being concerned that their seizure medications may cause fetal harm and such. Many women may misunderstand and abruptly stop their medications. Here are the current guidelines. Just gonna go back one more page. Here are the current guidelines that were recently published through the American Academy of Neurology in collaboration with the American Epilepsy Society and the Society for Maternal and Fetal Medicine and Child Neurology. And it emphasizes three key points throughout the three key stages of pregnancy care. It emphasizes the incredible importance of preconception counseling. Most of the heavy lifting is done before a woman becomes pregnant. And the importance of three top prescribed medications, Lamotrigine, levetiracetam, and oxcarbazepine. Those are the top prescribed, but also medications with the lowest risk of teratogenicity among the available ones. There is now emerging signals that not only valproate, which has been consistently associated with a high risk of major congenital malformation, but also topiramate and phenobarbital when possible. And supplement this with folic acid. If anyone has been involved with the epilepsy literature, there has been some controversy as to what is the upper safe limit of folic acid, but the big take-home point is that all women should be on at least 0.4 milligrams of folic acid in the few months prior to conception. And then finally, what's an interesting signal that we can help advise and counsel our patients on is that the 9 to 12 months prior to conception is an important predictor of seizure freedom during pregnancy. During pregnancy, there's been an emerging role of minimizing tonic-clonic seizures, as well as abruptly stopping or lowering medications with the concern of seizure breakthrough, as well as the monitoring of therapeutic drug levels, particularly of the medications that have been known to lower during pregnancy. And finally, pregnancy, as Dr. LaHue has rightfully and so nicely demonstrated, is really 4 trimesters. And the post-pregnancy care is equally important in managing dose readjustments of medications, as well as supporting breastfeeding if wanted. And here are the numbers that are across the international registries. Each registry has important nuances and cannot be combined. But in general, registries from across the world have identified valproate to be consistently a concern. And so a take-home point really is that if it can be avoided, and for some women it cannot, if it can be avoided, valproate should not be ever the first line therapy or first choice therapy for women of reproductive potential. For some women with genetic generalized epilepsy, it may be the only drug, however, that can control their seizures. Lamotrigine, carbamazepine, and phenytoin are within the mid-range, with lamotrigine in the lowest range. Phenobarbital is rarely prescribed in North America. However, it is the most prescribed anti-seizure medication across the world. For pennies a pill, it is an affordable anti-seizure medication regimen. And so with the large immigration populations in particularly urban areas, it's important to identify phenobarbital use and counsel women on the associated risks. This is a very nice pictograph of the general risks. I have it posted in my office for women to visualize. And at the far right is high-dose valproate, inferring a 14 times increased odds ratio for major malformation. Whereas Lamotrigine, which sets the standard across the dotted line at 325 milligrams total daily dose, is what many of the seizure medications are compared against. One really important take-home point for this graph really is that this is a dose-dependent observation amongst our registries. The higher the dose, the higher the associated malformation observation rate. And so with valproate of less than 650 milligrams total daily dose, that is comparable to carbamazepine 700 milligrams total daily dose. And so this is a nuanced conversation that physicians should have with their patients, in that if low-dose valproate can render someone seizure-free and is the only medication available, dose-dependent alterations could be considered and counseled on. There is really an exciting movement in epilepsy in providing evidence-based data for counseling and caring for pregnant patients with epilepsy. Dr. Pinnell, leading the MONEED study, has really identified that contrary to urban legends in that seizures can worsen during pregnancy, in fact, if we observe two cohorts of pregnant women with epilepsy versus non-pregnant women with epilepsy, followed throughout pregnancy and across all seizure subtypes, there's absolutely no difference in seizure frequency in the observation period. What is interesting is that the women who were in the pregnancy cohort had 3 times the rate of dose adjustments of their seizure medications. And so this, though this was not a randomized controlled trial in pregnancy, it is probably the most robust data set that we have to inform how we care for our women with pregnancy, as well as a really important reassuring signal that under expert care and following guidelines, women have just as good of a chance of remaining seizure-free during pregnancy as they did prior to pregnancy. And what are those dose adjustments? It's informed by what we know of the medications. The top 3 medications prescribed across North America, Lamotrigine, levetiracetam, and oxcarbazepine, are known and recognized to fall during pregnancy, but at interestingly different time points. For Lamotrigine, the first increase is in the first trimester, but it consistently falls throughout every single trimester. In the black line up to the top left is levetiracetam, and it tends to have the greatest plummet in the first trimester, whereas oxcarbazepine in the orange line and topiramate in the purple line tend to have the greatest plummet in the second trimester. And so knowing the pharmacomechanics of this drug metabolism during pregnancy will help inform when you should be on guard to adjust medications based on available drug levels. And Paula Brunescu in Harvard at Boston really has done a wonderful job in helping us guide when we make those adjustments. In fact, across the dotted line in the lower graph there, we see that when the pre-pregnancy serum levels versus the in-pregnancy serum levels drop by greater than 30% comparatively, women have an increased risk of breakthrough seizures during pregnancy. And Lamotrigine is fascinating in that there is a growing body of evidence that there is variability in clearance. Looking at this clearance graph here, you're seeing that consistently throughout all the trimesters, Lamotrigine clearance increases and then suddenly drops in the postpartum period. This raises a significant risk for women to go into Lamotrigine toxicity. What's another interesting signal is that there is a cohort in the triangle red data sets that there is no increase clearance of lamotrigine. And so adjusting lamotrigine doses, if lamotrigine serum levels are available, would be missing a cohort of patients who actually don't have increased lamotrigine clearances, leading into lamotrigine risk of toxicity during pregnancy. And one of the emerging signals from this is that there may be genetic polymorphisms of the important enzymes that glucuronidate the lamotrigine molecule. Glucuronidation happens in the liver, where the liver identifies lamotrigine, tags on glucuronide so that it can be identified downstream to be metabolized. And so UGT1A4 is the main isoenzyme that helps with this metabolism. And lo and behold, there are genetic polymorphisms that are identified throughout different countries and populations that can impact how quickly lamotrigine is glucuronidized. If you see here in the Nordic population, where Denmark is actually producing a lot of incredibly rich pregnancy-related data because of their healthcare system and data collection, we're seeing that the polymorphisms of CA, particularly in women, which is in the speckled black bars to the right, have a more dramatic increased risk of lamotrigine metabolism. The second influencing factor is estrogen. And what we know that in pregnancy, estrogen and progesterone increases by 100 times. And what's even more fascinating is that it's not estrogen produced by mom. It's estrogen produced by baby and the fetal liver. If you look here during pregnancy, the yellow line there is estradiol, that is pregnancy-related estradiol, and it's synthesized by the fetal liver. Whereas in contrast, in the red line, where in the non-pregnant state, estradiol really doesn't have a major impact on serum levels in pregnancy. And finally, understanding that as the fetal liver produces estradiol, it is actually the estradiol content of the maternal serum levels that better predicts how quickly lamotrigine is cleared in contrast to the gestational week. There's been some early signals, and it's still yet undefined whether female fetuses, which produce more estradiol than male fetuses, have an impact on maternal lamotrigine clearance levels. So it's an incredibly exciting time in terms of basic science research, in terms of clinical care, patient advocacy, and education in women's health, especially in epilepsy. The epilogue to Sadie-Givant syndrome is that her lamotrigine level was actually 65, and she was diagnosed with postpartum drug toxicity. She probably had the genetic polymorphism that caused the rise in clearance throughout pregnancy. Her myoclonus worsened with lamotrigine, and as you lowered the lamotrigine levels down to 125% of her pre-pregnancy level, she slowly improved, and the toxicity symptoms improved as well as the myoclonus. And when you saw her in follow-up 1 month postpartum, she was carrying with her her beautiful, healthy baby boy. So in summary, hopefully throughout these 2 cases, one of the challenges will be to really look at the patient and ask yourself whether your care would be any different whether this patient was pregnant or not. And if pregnant, is this the underlying disease process or a new pregnancy-related disease process? Identify the important peripartum neurological complications that can continue on in the first few days, if not subsequent months of our 4th trimester. And then the management of seizures in pregnancy can be very different, whether it's the acute presentation of a new illness, as Dr. LaHue has demonstrated, or the symptomatic presentation of a chronic illness. And the hope is that as we present these cases and share with the group the evolution of women's neurology, that more and more research can be done in including pregnancy as a criteria, not as an exclusion criteria in our research and clinical care. I'd like to acknowledge, really, this is Dr. LaHue and I representing a larger group, and this is the founders table of a really wonderful network of collaborators and educators led by Dr. Janet Waters, Dr. Angela O'Neill, Dr. Alexandra Picula, Dr. Amy Hessler, Dr. Riley Beauvais, and Dr. Divya Singhal. The 8 founding authors of the women's neurology curriculum. But as much like the pregnancy and maternal care roadmap that Dr. LaHue represented, this roadmap is even more sparsely populated. And where there is a gap, in my humble opinion, there is an opportunity, and the opportunity is huge for us to call out for collaborators, innovators, and future leaders in this field, because the roadmap is still to be drawn. So with that, I want to thank you, and happy to entertain any questions of Dr. LaHue.
There is one question in the Q&A, and it says, can the speakers comment on IVF and considerations of stroke risk in patients who have had a prior stroke?
Great, so that's an excellent question. And this is something that is a project that we're actually working on together, and hopefully we'll be able to talk about more concretely once it's published. But I think in terms of the question about stroke risk, that's going to come down to what the underlying etiology was for that particular patient, whether or not it was related to a particular factor, specific to that person's pregnancy, or what the other factor might be. And so sometimes in the case of the development of venous thromboses, there may be the use of anticoagulation that's used for subsequent pregnancies preemptively to reduce the risk. But again, this is going to be something that's going to be a case-by-case basis, and depending on the kind of stroke the person had, and what the underlying risk factor is thought to be.
There was one other question that just came in. How often should drug levels be monitored in pregnancy?
That's a great question. Emily Johnson from Johns Hopkins did an interesting small study to see if there's a difference between blood work done every month versus every trimester, or once during pregnancy. And the early signals are there is no significant difference if dose adjustments can be done. We don't know the answer to that question, and so challenge you to reflect on your own practices and your preceptors' practices to see what people do. In my practice in Canada, I do monthly levels. I don't necessarily see women monthly, but on at least once a trimester. On the flip side, the most important drug level is the preconception drug level. And so to challenge you with viewing every woman who comes through your practice is a preconception visit for their neurological condition, to review and refine the family planning goals for women and their families, and for epilepsy patients to have a preconception level. That will help guide any downstream important therapeutic decisions that you have.
So I think a question I would have for Dr. Bui, since this is a topic that you enjoy both talking about as well as writing about, getting back to the point about inclusion criteria, and really thinking about how to include pregnant patients rather than exclude them. How do you think we might be able to make some headway in that?
That's a great question, and reflecting on the journey that epilepsy has had, and the profound harm that one could do by not including women in pregnant states is that not knowing the absence of data is not the data of absence, and vice versa. So I think informing and counseling patients when there is a data void is equally harmful than including women in studies and trials. I think one of the challenges will be that randomized control trials will be very difficult to enroll patients who are pregnant or intending to be pregnant. But that doesn't eliminate observational data, much like our pregnancy registries, as well as collecting data when women unintentionally get pregnant during any study. And so having that part of the data set will be important. I'm going to turn this question back to you, Dr. LaHue. Where would you see our fastest ways to make change in including women in pregnancy in our research?
I agree that the use of registries is an important resource that I think we need to leverage more and make sure to educate our patients on and make that a priority to talk about in these patient visits, especially for patients like you mentioned who may be on medications when they become pregnant, and that gives us an opportunity to also understand the trajectory with use of medications that maybe we wouldn't have otherwise chosen for that patient in the setting of pregnancy. I think making this a priority to talk about is certainly a step forward. I think that being able to highlight these gaps and talk about these cases and garner more interest in I think appreciating what these gaps are. I think also just will also hopefully create more buy-in from the trainees that we're speaking to hopefully join us in this particular cause. At least at the very least, to just consider this when you're seeing patients in the hospital or in the clinic, to think about the kinds of questions that you might be asking in terms of reproductive choices or symptoms related that may be related to changes in hormones or across the lifespan. And so I think really the first step is just recognizing that these are important variables for us to pay attention to when we're caring for patients with neurologic conditions.
If I may ask my own question for you, Dr. LaHue, from a neurohospitalist perspective, what are some really key kind of low-lying fruit interventions that you can see in the interface of hospitalized or acute presentations of pregnancy? Are there things that you're noticing that we could do better for our patients?
Well, I think collaboration with the different subspecialties is key here. So having established relationships with OB-GYN, maternal fetal medicine, OB anesthesia, and neurology, I think having those partnerships in place is really helpful if one works in a hospital environment with those kinds of resources. And then I think it gets back to the question on the last slide, which is just thinking about one's management decision and whether or not that would change if someone was or wasn't pregnant. And so this is where I think asking oneself about access to especially acute therapies like thrombolysis or mechanical thrombectomy, or sometimes we'll also talk about things like post-cardiac arrest care and targeted temperature management. Recognizing that pregnancy itself is not a exclusion criteria for these acute therapies, but rather really looking at it from a case-by-case basis and talking with, again, in a very interdisciplinary format around whether or not some of these acute therapies would be appropriate for the patient in front of you.
I see there's a third question in the question and answer section. Is warfarin the only option for anticoagulation in women who are breastfeeding, or is there data on the safety of DOACs?
Yeah, great question. So right now we're still lagging when it comes to safety data around DOACs, at least when I was reviewing this while preparing this talk with Dr. Bui within the past few weeks. And so things like low molecular weight heparin, which in the acute period, great, but certainly that's not going to be realistic longer term. Warfarin ends up being a safer option when it comes to breastfeeding. But hopefully, again, if we keep collecting data around in the setting of registries and those kinds of things, hopefully we'll be able to move the needle when it comes to understanding safety of DOACs as well.
So Dr. Bui and Dr. LaHue, thank you for presenting today. We really appreciate it.
Thanks for inviting
Thank you
us.
for having us.